Hi, Allison.
Hello.
Thank you so much for coming on and agreeing to speak and tell your
Yeah, of course.
knowledge. So
Speak my facts.
your facts. You were a labor and delivery nurse, but now you're NICU.
Yes.
How long were you a labor and delivery nurse?
So if I would have stayed, it would have been 2 years as of
Oh,
March. So
awesome.
before that, I did postpartum for 11 months. I always go like before the year mark. It's so funny.
Yeah.
And then I did labor and delivery for about you know, I'm like a mom with a toddler, like 18, 24 months.
Yeah.
But for almost 2 years. And then I've been in NICU since the beginning of February of this year.
Oh, cool. Okay,
Yeah.
so why don't you just introduce yourself and then we'll get on with the questions.
Yes. Okay, so my name's Allison Clark. Like we said, I've been a nurse for it'll be 3 years in a few days, so that's crazy.
Hmm.
I started out in postpartum, which is some people know it as mother baby. And then after almost a year of that, I went to labor and delivery, did that for about a year and a half. And then due to wanting like a job change, I swapped to NICU just to try it. So I've been in NICU, like a level 4 NICU for the past few weeks. It's been fun. It's been crazy. Lots
Stressful.
of learning. Yeah, stressful. Lots of learning experiences, but it's yeah, I love it. I am trying to kind of get back to labor and delivery because I just miss it so much. I'm like so passionate about it. I like
Hmm.
literally see pregnant women. I just want to talk to them about
Yeah.
their pregnancy and how they want to deliver and all of that.
Oh,
So,
yeah.
but I'm having fun. Like being in the NICU for sure will make me a better labor and delivery nurse.
Yeah.
So,
So what about your personal life?
oh yeah. I know. It's like such a big part of my personality being a nurse. It's like my
Yeah.
number one thing. But I have a baby boy. Well, he's more like a toddler now, which is
He's
really
so
sad.
cute.
Thank you. His name's Calvin. He's turned 1 in January. I'm really bad. I'm like, I guess that makes him 14 months.
Yeah.
Yeah, as of a few days ago. And me and my husband Robert have been married for 6 years. It'll be 7 years
Wow. Oh my goodness.
this July. I know sometimes I'm like, because we got married when I was 20, and I'm like, I'm old enough to be married for like 7 years. Like,
I
that's
know.
crazy.
My 10
I
year is
know.
next year, and I'm like,
Oh my God, how
I am
exciting.
not
I
old
guess I shouldn't
enough
say
for
that, but
that.
I know how exciting. Are you planning
Thank
anything
you.
fun?
Um, Hopefully, yes. We're in the middle
Yeah,
of like a house remodel, and it's
girl.
like a
I
hot
know.
mess.
I see your reels and videos, and I'm like, oh
Yes.
my gosh, she has the house of all of her dreams. Like
Oh, well,
those
not right
views.
now. Hopefully
You're
soon.
like, it will be one day.
Yeah.
Yeah, we bought our first house in the middle, like literally December 2020. Do not recommend when I was
Oh
like
boy.
8 months pregnant,
Oh yeah.
but we got it. So I'm also a homeowner too, and that's fun. So thank
Awesome.
God,
Yeah.
because it was
Yeah.
such a blessing. Such a
Yeah,
blessing.
for sure.
Yeah,
Let's get into the first question. The hospital
do
bag.
it. Yes.
What are
I
like the
mean,
main?
what's essential since that's a
Yes.
buzzword?
Yes.
Yeah. So honestly, in terms of like what's essential, the hospital will actually provide you with like the most bare, basic, essential things. You could honestly go to the hospital with nothing and just a change of clothes when you go home, and you actually could have everything you need. I'm sure that varies from hospital to hospital, but most hospitals I know like will provide you toiletries, like body
Mm-hmm.
wash, hair wash, diapers, wipes.
Yeah.
Where I used to work, we even gave like a little going home outfit for the babies. I mean, your baby
Aw.
might not fit in it, but
Yeah.
that's something to keep in mind. If something happens and you're in a rush, don't stress about your hospital bag. Literally bring like
Just clothes
change,
mainly.
change of clothes, a change of clothes for baby if you can grab it, and like a cute baby blanket if you know, because we all want like that cute Instagram moment of
Yeah.
your baby
Yeah.
being swaddled. But okay, so like if you're more prepared, um, fun thing. So what I did is I have a very morbid nurse brain, and I always think of the worst, which you know, I think. Well, I should say I planned really well. So I was like,
Mm-hmm.
okay, if I'm induced, It'll take 2 or 3 days. And then if my baby goes to NICU, which, newsflash happened. So I guess I had but some weird inclination, then I'll need a few more clothes. So I overpacked just because of those things, because I just thought of, but in general, that never happens. So if you are induced, I would bring maybe 2 or 3 changes of clothes. Your husband, I would say to bring more, 2 to 4 changes of clothes, because if you're induced and it takes a day or two, he may not want to wear the same thing a few days in a row. Tell him to bring joggers, tell him to bring something comfortable to sleep in, a sweatshirt, because
it
gets cold in the hospital, and bring they'll give you blankets. So don't bring a blanket. Do not bring your whole house, because carting all of that in and then carting it all out with a baby is a lot. So we brought one weekender bag and we fit all of our clothes in it. So I had my side, his side, 2 or 3 changes of clothes, the baby's clothes, and then we just kind of combined our toiletries as best as we can, toothbrushes, toothpaste, and then our own deodorants, obviously. If you want to bring something that'll give you comfort, I know people like to use essential oils, pack those in your bag. And just anything that'll make you feel comfortable. Some people like to bring little lights, but keep it light, keep it not so much. Maybe a little speaker would be fun, a teeny tiny speaker
for music.
Bring your chargers, bring your phone chargers.
Yes.
And then my husband and I have a wireless charger, because you might run out of outlets, or your phone might not reach if you plug it into the wall at the hospital. So
that's true.
A portable charger. And then for baby, don't bring wipes, don't bring diapers. They will give you
have all
those.
that. Yeah.
Yeah. Don't bring your own soap, because most of the time, for legal issues, they can't wash the baby with your soap. They have to use soap that's been approved by the hospital. So
okay.
Yeah, you can bring baby lotion. They won't put the lotion on the baby, because also, they gotta be liability issues, but you can put lotion on your baby, and bring a blanket and 1 change of clothes for on the way home, because up until then you want to just, keep your baby in a diaper in the hospital shirt or blanket they give you, because they'll be assessing the baby. Your baby's going to spit up, have a blowout.
That's true.
So
that's true.
I always tell people, for ease of packing, just bring 1 outfit for baby to go home in, and then maybe 2 if you want a little outfit to take
a picture,
here's our baby picture.
Yeah.
So
that's good.
I keep it light, keep it practical. Bring 2 or 3 things that I would say are essential. Bring your own snacks.
Oh yeah, that's good.
Because when you're breastfeeding, you will be hungry.
Yes.
Bring a water bottle with a straw, because it's hard to focus, on drinking like this when you're in labor, or when you're breastfeeding a baby. And have a music playlist. I had a playlist going while I was pushing, and it was so much fun. So
that's good.
Yeah, those are some fun things to bring.
Okay, so for first-time mom, when do professionals say to go to the hospital once you think you're in labor? I know the biggest fear is going and either going too early and then getting sent home, or going too late and having a baby in your house.
Or in your car,
or in your car
this year.
Yeah.
So on that note, it's really rare with your first baby that they're gonna fall out.
Right.
So I want to give that, if you're trying to go natural, staying at home as long as you can is a really good option, because you're in the comfort of your own home. You're not being strapped down to monitors, all of that. Whereas, there is recommendations to being monitored during your labor. So don't stay too long, especially if your water breaks. So things to go to the hospital immediately for. If your water breaks, you need to go, because they need to monitor, make sure baby's okay, because that shifts the baby's position. We want to monitor baby and you in case you get an infection, especially if your GB is positive. They have to start antibiotics. That prevents a lot of issues related to infection and sepsis in babies. As long as you have 1 or 2 doses of penicillin in you, your baby should be completely fine, protected from the GBS. Even if you don't get those doses, they're usually fine, but you want to take that extra precaution. If you're in labor and you have any kind of vaginal bleeding that's deep dark red, or sudden abdominal pain, go to the hospital right away. If obviously decreased fetal movement, those things, go to the hospital right away. Don't wait.
Don't chance it.
If you feel pressure, like you want to poop,
go
to the hospital right away.
Yes.
You're first time mom, you may not push your baby out on the way in the car, but you never know. Like I've had first time moms push their babies out in 5 minutes and wow me.
Yeah.
So those are the things, go to the hospital right away. Now, if you're in like labor and your contractions start, and you want a guideline of when to, how long you should wait, when you should go, we have something called the 5-1-1 rule, where your contractions are 5 minutes apart, lasting 1 minute and those contractions are lasting for at least an hour.
Okay.
So you really want, at least how I look at it is, you want 2 to 3 contractions in a 10-minute period, lasting for at least a minute. And you want that to last for at least an hour. That is the best indicator that you're probably in active labor and you're at least, closer to 4, 5, 6 centimeters.
Okay.
And that's when you want to go to the hospital. Some people, that might be really painful for them before that point and getting to that point. So you can go get checked out. Sometimes they will let you walk. If you're only 2, 3 centimeters, but you're in a lot of pain, they'll let you walk. And if you make any cervical change, they'll keep you. Sometimes if you're 4 centimeters and you're not quite in what they consider active labor, 5, 6 centimeters, but you're in a considerable amount of pain, they give you pain meds. It doesn't really help. They might keep you so that you can get an epidural.
Right.
It all really is based on the doctor's discretion and, the hospital policy. But the number one thing that is going to get you admitted is if you are 5 to 6 centimeters, contracting, at least every 2 to 3 minutes, lasting at least 60 seconds, and for 30 minutes or an hour or more. And then obviously if your water breaks and all of that. But that is like the golden rule. If you don't want to get there too early. And then if you don't want to get there too late, I would, once you start feeling those more regular contractions and you feel like a shift in intensity, and you feel a shift of, I can't talk through these anymore. I can't, I'm getting a little bit harder time catching my breath. I'm getting a little bit harder time, speaking or being able to do anything but concentrate through these contractions, I would go in.
Once you get there and they checked you and they're like, okay, we're going to keep you, what is the process? And I know it's different. This is all of this stuff is kind of hard because, one, I know it's like every hospital is different. And I know every pregnancy, every patient is different. So just keep that in mind, everybody.
Yeah. Well, so it all really just like starts in triage. And this is totally different if you're in spontaneous labor or if you're induced. Do you want me to go through both really quick or?
Yeah.
Okay. So if you're in spontaneous labor, you'll come in, you'll go through triage. This is always the funniest part. You hear about it in stories where like registration is checking you in and you're like trying to answer these questions.
Yeah.
And like breathe through it. And they're asking all these questions, but I mean, it's just part of the deal. You go through triage, they'll assess you, they'll hook you up to the monitor first thing, get some vital signs. Usually the doctor will come in and do a vaginal exam. And then if you're, the token like 5, 6 centimeters or your water's broken. If you say your water's broken and they don't see a lot of leaking, they might do a few tests to see, like a vaginal swab or a Fern test, and that might take an hour to get back. Then, and if your water's broken, then you'll be admitted. If you have any kind of like high blood pressure or any kind of abnormalities in the fetal heart rate, you're going to get admitted. If you're having contractions and you have any kind of fetal heart rate abnormalities or blood pressure issues, you'll most likely just get straight admitted.
Okay.
If you're an induction, you'll just check in at registration and you'll come right back to a room. And that's where we'll hook you up to a monitor. First thing, you should always be put on the monitor. And then you'll get asked, and then also too in triage, these kind of go together, whether you're induced or in triage, you'll get asked a lot of questions like your history, your, physical history, any surgeries, any health issues, any substance use, history of any infectious diseases. They'll screen you for COVID and your partner for COVID. Another big thing about that too is until you're admitted, where I worked, the partner wasn't able to come back to the room with you. That might be different. So you might be in triage or in your room alone for a little bit. And then we'll start an IV and we'll give you a bolus of fluid. This is where I used to work. Other hospitals might be different, but in general, if you're admitted to the hospital, we want you to have an IV. And I know there's a lot of debate on whether you need one or not. I'm going to come from a strictly nurse perspective. I want all my patients to have an IV, even if we don't have fluids infusing, because God forbid something happens. You don't want us you just don't want us in the heat of the moment trying to get in.
Yeah.
You want to cut down as much time as possible in an emergency so that we can just do what we need to do to make you and baby safe. So if you're considering declining IV, I totally understand why they are super annoying. But it is based on evidence and our best judgment of that's the safest and fastest way to get emergency medication into you. Mm-hmm. We usually hydrate people as soon as they get there because most pregnant women are dehydrated. Mm-hmm. And that will not only make your contractions more painful, it will make them less effective because really your uterus is just irritable. And those contractions you're feeling may not be real good contractions. They're just uterine irritability. Well, that's just causing you pain and you can't sleep and stuff and stressing you out. So we'll hydrate you. And then we'll ask you, do you want an epidural? What's your plan? And once we know that answer, we can kind of plan out our night. If you're being induced, most likely you'll be started with something called Cytotec to soften your cervix. And then if your body just naturally goes into labor, that's all you'll need. If not, then they'll move on to Pitocin or a Cook's balloon or something like that. But basic thing is you'll get in, you'll be monitored, questions asked, IV started, IV fluids, and then based on your particular scenario, you might have a few more things happen, but we just if we start an induction, we just give you some meds and then let you sleep all night and you can get IVP medication. Or if you're in spontaneous labor, we see if you want an epidural, and if you don't, if you want IVP meds, okay, you don't, cool, then we'll support you in your natural, the way you want to have labor naturally.
Yeah.
And then a C-section is a whole different thing. So
I actually was going to bring that up.
Yeah. You basically just, for a C-section, and I'm just going to go off of a scheduled C-section, the night before you won't be able to eat anything by mouth starting at midnight. So don't get a Starbucks on the way. Yeah. We literally had a lady get a banana milkshake on her way to a C-section. And then she had to be delayed for 8 hours because your anesthesia provider will not put any kind of anesthesia in you if you have something in your stomach, just for something called aspiration precautions, which makes it's a whole really rare thing, but they just have to do it, for their liability. But so don't eat anything by mouth, starting at midnight the night before. And then sometimes what we did is we sent you home with CHG wipes, and you'll wipe yourself down the night before or that morning. And that's just basically prepping and cleaning your skin for the surgery. And then when you get to the hospital, they'll also ask you to shave all your lady parts down there. But if you're not able to, we'll shave you when you get to the hospital. We'll wipe you down again with some CHG wipes. We'll put your baby on the monitor, start an IV. You get 2 bags of fluid if you have a C-section, because we want to bump up your blood pressure, because you'll get medications that can lower it even more. And then we want your blood volume nice and bulked up, because you're more likely to bleed more during a C-section. And then sometimes too, the anesthesiologist will give you we'll come in and give you something for nausea and then something for heartburn. Because those are things that people feel a lot. Oh, and sometimes something for itching too, because those are all things that you'll feel with anesthesia sometimes. But yeah, you'll basically get a pre-op workup when you get there, just wipe down. Some people may want to try to give you the Foley catheter before you go in the OR. Don't let them. Say, I want it after my spinal is in, because it is uncomfortable. So
okay, that's good to know.
Yes. if they don't give you the option, speak up and say that, because there's no reason why they can't do it in the OR. So there's my little plug for
Yeah,
advocating
that's
for
good.
yourself.
Yeah.
And then, you'll basically just wait, and then they'll either wheel you back or walk you back to the OR. And the OR can be really scary sometimes. Just breathe, just be relaxed, and just know that this is something that OBs and L&D nurses do literally
all the
every
time.
single day. Yeah. And it's very routine for us, even if it's not routine for you and it's really scary. So just put that trust,
Keep that in mind.
and anxiety.
Yeah.
It's scary though. I totally understand.
Oh yeah.
Once you're in the OR, so for my hospital, we would sit you up on the bed. Well, we'd we put the baby on the monitor. Or no, actually, we sit you up on the bed and we get the spinal in. Anesthesia basically goes into a certain area of your spine where they put some medication in. It's not an epidural. I think sometimes they can, if you're already in labor, they can use an epidural catheter to give you a spinal. But the spinal is basically an injection that numbs you from the waist down. Some people too get like numbed from like the chest down, which I know is really scary. So just be aware of that. And then they'll lay you down. Most likely your arms and legs are going to get strapped down. That way you just don't fling around.
Yeah.
Your belly will get prepped. They'll prep your belly with like a surgical antiseptic prep. They'll put the Foley catheter in, and at that point, because you have the spinal in, you really shouldn't feel it. And then there will be the hustle and bustle of everybody getting ready, everybody showing up, like NICU, respiratory therapy, the doctor. Once the doctor comes in, we kind of get everything ready to go. They set up the sterile field. And then once the sterile field is set up, everybody's in the room. We stop. We do what's called a timeout, where basically we go over the patient's name, medical record number, condition, why we're doing what we're doing, the exact surgery we're doing. And everybody agrees and introduces themselves. So the patient knows exactly what's going on. We all kind of know like pertinent information, and just make sure that we're operating on the right person at the right time, in the right area. And then they'll do like a pinch test. And if you feel anything, like if you feel any kind of pinch or pressure, you have to let them know, because then they need to numb you up a little bit more. Because obviously no one wants to feel that.
You'll feel it,
you will feel really weird, like pressure from them, especially once they get in there and start pulling the baby out. And I've seen a lot of anesthesia. Usually the nurse is actually just like walking around counting stuff, making sure the sterile field is intact. That I've seen the anesthesiologist is actually your best friend in more ways than one during a C-section. They're talking to you in your ear, telling you what's going on, giving you medication so you feel good, and kind of walking you through stuff. So they'll be your best friend during the C-section. And, like I said, it's so scary to think about, but it really is like a very routine procedure that, L&D is very used to. So you should get a lot of comfort. And then there's things you can ask for too. Some hospitals let you have like a clear drape or a more gentle C-section, or you can play music during your C-section. So
that's
like
cool.
I always tell people, look into those options, because I was in a C-section 2 weeks ago at my new job following the NICU nurse down there. And it was so sweet. Like they had a clear drape. They pulled like twin A up and showed the mom and dad. And then they pulled twin B up. And it was like, honestly, the most chill C-section I've ever been in. And it was so sweet. So you can have a really sweet, like good experience with the C-section.
It doesn't have to be negative or scary.
It doesn't have to be really negative or scary. So
especially if it's scheduled.
If it's scheduled, it should not be scary.
An emergency is different, because you don't know what's going on. You weren't planning that.
Exactly.
But if it's scheduled, it's almost, I don't want to like say the wrong thing or sound wrong. But it's almost kind of cool that you kind of know when you're going to deliver. That's like an upside,
that is,
when you are giving birth naturally, you're just waiting for your body. You have no time, no day. It can happen. And that can get like really stressful. So the upside to that, having it scheduled, is knowing when and being able to prepare and plan for that. So
it's crazy. Yeah. Like, oh, you wake up that morning and you're like, I'm going to have my baby
yeah. When
in
you
a few
normally wouldn't.
hours.
Yeah.
Yeah.
That's so cool. Okay.
Yes.
So I have, next we have talking about epidural, and
Yeah.
this is a really hot topic.
Mm-hmm.
This is a big question that a lot of first-time moms have. And some people don't want it at all, and that's totally fine.
Yeah.
For me, when I had my first, I originally didn't want it. It was out of fear for like,
Yeah.
it hurting, or I don't like needles or anything like that. And I made a huge mistake. And I just want to say this. Do not watch a video of an epidural before.
Yeah. Don't watch it.
It looks way worse than it actually is, because I did that when I was about like 7 months pregnant with my first daughter.
Yeah.
And I was sitting on the couch.
So
I'll never forget this. I was bawling because I was like, I wanted the epidural because, not being in pain, but I didn't think I could get the epidural because I was so scared.
You saw
of what
that needle.
Yes.
Yeah.
And I'm like, okay, well, what are my options? What am I going to do? I have to, like, this baby has to come out now.
It's coming out one way or another,
So
yeah.
don't
no,
do
I get
that.
it. Yeah. Don't do that unless, you're like 100% for the epidural and you're just curious. But yeah, I agree. I wouldn't recommend, because
For me, though, in the moment when I did get the epidural, it seriously was not. I mean, it was a pinch. All I felt was a pinch in the beginning, which was the numbing before they actually put the epidural in. And then that was it. I felt nothing else.
Did you feel like no pressure from the needle or nothing, right?
No.
Yeah.
Okay. And sometimes you do feel that. Yeah.
I was like prepared to be like the best patient during an epidural. I was actually kind of like bad. Like, they say don't move and all of that.
Yeah.
So I felt the pinch, which the guy who did my epidural is amazing. Every single patient who was, I'd have, and he was working that night, I'd be like, oh, James did my epidural. If you want to get an epidural, you should get it now because James is great. Yeah. But I think because I knew what the procedure looks like and stuff, I was like in my head too much. And when he put the actual needle in, I felt a little bit of pressure. So you might feel a little bit of pressure like in your back when they put the actual,
but it's
so
not
basically, and here's
pain.
The thing. No, it is. And if it is painful, then you're either not numbed up right enough or they're not doing it right. So you should make them stop if it's painful.
Tell them,
that's my number one thing I wanted. Yeah. Hey, this is hurting. Now, I know everybody has different pain tolerances. So you really have to reframe when you're going into labor. You really have to reframe your idea of pain. And you really have to get in your brain that pressure is not pain. Pressure is an uncomfortable feeling. It is not pain.
Right.
So that's like my number one mantra to moms. Like, hey, listen, especially if they get that epidural and they were having crazy painful contractions. And then later on, when they're 10 centimeters, they're feeling that pressure and they start freaking out. I'm like, listen, this is not the pain you're feeling before. This is pressure. And I understand because I felt that pressure and it is intense.
Yeah.
But at the same time, you use that. We'll talk about that later, but that is your gateway to getting that baby out. So we can go over the epidural. I love epidurals. Highly recommend. Like Lauren said, don't watch a video before because you'll be in your head too much, unless you're a medical professional and that kind of stuff doesn't bother you.
I mean, if you really feel like you can handle it,
maybe mentally help you. I don't know, but it really is. If you have a good, and I'm going to preference this by saying, all epidurals should be the same, but not all anesthesiologists or anesthesia providers are the same.
Right.
So you might want an epidural and the person that may not be that great at giving epidurals. Now, that is where I always tell moms to really advocate for themselves because there is always a second person. If your epidural is not working, there are like 4 or 5 things we can do to help. But, advocate for yourself, make sure your nurse is advocating for you because there are great anesthesia providers and there are not so great anesthesia providers who can get an epidural in really easily and it'll work wonderfully. Or I've been in those cases where it's taking a ridiculous amount of time based on whatever factors, and then it doesn't work that it works for 4 hours and then, whatever. So advocate for yourself, because if you're getting an epidural, you should 100% get the chance to enjoy it. So whether it's they need to bring someone else in to give you this epidural, or they need to grab the second person who's on, that is totally doable. A lot of times, wherever you're at, nurses, doctors may make you feel like you're being an inconvenience to them. You're not. It's more inconvenient for them for you to be in pain,
right,
and experiencing, when you want this epidural, and to be in pain, and for us to try all these interventions when we can just have them redo it, which I've seen work beautifully, or we can just get someone else to do it. Who might be faster and better.
I didn't realize that you can get your epidural redone.
Yes. So if you get an epidural, it usually should only take 10 to 20 minutes max. If it takes a little longer, things that might affect the ability to get the epidural is a lot of women, if they've been in labor for 1 or 2 days, kind of like an induction kind of thing, a lot of laying on your back or in the bed, you'll get a lot of swelling in your back just from all the fluids you're getting and just from laying in that position. So that puffiness in your back makes it kind of hard for them to find the space. They're basically feeling your spine, shooting for a space in your spine that actually goes a little bit past your spine to get that epidural catheter in. So any kind of edema, tissue, any excess tissue. Sometimes some anesthesiologist providers will say scoliosis or any spine abnormalities, but I've had a lot of anesthesia tell patients like, oh, it's okay if you have scoliosis, we can still do it. A lot of moms with scoliosis are really scared about getting the epidural when it's actually not that hard for them to get. If you have a good anesthesia or even a mediocre one, they can do it. And then obviously if you're able to stay still. So the biggest thing you need to get an epidural is obviously A, you need to consent, and B, you need to be able to sit still. It is never too late to get an epidural.
That was my question.
Yes, it is never too late. We've literally had someone who was 10 centimeters and pushing for an hour get an epidural. I have had a mom who, and here's another factor, if you only have, I had a mom who was 9 centimeters, first time mom, who I helped her get to 9 centimeters without an epidural. I'll talk about situations where you might not get the epidural right when you want to, but long story short, she did so good getting to 9 centimeters. I told her, hey, we're almost to 10. You can either push this baby out without one and pushing will be less time, or you 100% can get your epidural still. And she was like, I want my epidural. I was like, okay, you deserve it. Like, she did so great. When I got in there, she was cussing and screaming and crying, and we got her to a place where she just laser focused and went from 3 centimeters to 9 centimeters, like so calm, so control over herself. And she did it. And then I was like, yeah, like we could get you an epidural, So it is never too late to get an epidural. And if that provider tells you that, then they're not confident in their own abilities to give you one. But if you are able to sit still, you can get an epidural at any point. Now, in terms of getting it when you're 1, 2, 3 centimeters, we usually don't say, oh, you can't get it then, but we don't recommend it, because if you're 2, 3 centimeters and you're first time mom, you still have you might have hours of labor left and you will be stuck in a bed. Yes, we will be changing your positions. You should have also too, when you get an epidural, someone should be changing your position every 30 minutes to an hour. You should never go more than 2 hours without your position being changed. That is what's going to stall your labor. People freak out, say, oh, the epidural is going to stall my labor. It's going to make it go slower. No, if you have an epidural, your labor will not stall if you're constantly being flip-flop from one side to the other. They use a peanut ball, those kind of interventions. It's people who their patient gets an epidural and then they're like, all right, have a good night's sleep.
They just lay there.
And they don't move them all night. I literally I have come into a patient's room and said, when's the last time your position was changed? And this is 7 p.m. at night. And they go, not since 10 a.m. this morning.
Oh no.
And it's so frustrating. So advocate for yourself. Know that if you get an epidural, your labor might progress if you don't move, but movement and getting your position changed, using a peanut ball, those are all things that are going to help you, your cervix change and all that. And we've had moms who have been stuck at 4 centimeters for hours, and they get their epidural, and an hour later they're 10.
Wow. Yeah.
So keep that in mind too, that relaxation, that finally letting go and your body being able to let go and relax can also really calm you down.
Yeah.
So before you get the epidural, we'll get consent. We'll do another timeout procedure. You'll get a lot of fluid because the epidural can drop your blood pressure. So we usually give like 1 bag of fluid, which is a liter of fluid. And then they'll sit you up for the epidural. You're going to have to sit on the edge of the bed. Usually we have you like hold a pillow, or the nurse will stand in front of you and hold your arms, and you kind of just curve your back like a C and push your back out to the anesthesia provider. And then, like you said, you'll feel a pinch when they numb you. And then after that, the only thing you should feel is some pressure when they're trying to get the needle in the right spot. You'll feel this funny pressure because they'll get the needle in, and then they actually inject fluid into the spot to see if it expands. And then once they see that they're in that right spot, they thread the catheter through, which is like a teeny tiny catheter. The needle does not stay in your back. That's another fear people have. It's a teeny tiny catheter, just like an IV. They use a needle to get in, but they take it out and just a tube is in there. And then they will, sometimes you might feel like a zing when they put the catheter in your back down one of your legs. I felt that. I felt like a zing down my right leg. And
I've heard that before.
Yeah. Because literally it's the catheter brushing up against a nerve. So they'll ask you, did you feel it on your right or your left? And then they might reposition the catheter based on where you said you felt it. 9 times out of 10, wherever you felt that zing, that is the side that your epidural is going to be heavier on. So your epidural might be heavier on one side or another. That's really common. And then once they get it in the right space, they'll give you an injection of medicine to test out if it's in the right spot. And they'll ask you to tell you if anything weird happens. That's basically seeing if it's not in the right spot. They give you a tiny bit of medication to make sure that they don't give you a big amount of medication in the wrong spot, because that can be really bad. So we have all these safety checks that we do to make sure the epidural is really safe. And then they tape it up really good so that you can move around. And where I used to work, we hooked you up to a pump. And if you felt any pain or any kind of sensation, you can hit a button and give yourself a little boost of medication, and it would take that away.
Oh, okay.
Yeah. And then sometimes, like I said, you might feel your epidural heavier on one side than the other. And people might feel pain like on their left side only or on their right side only. That is just basically meaning like your anatomy or where the catheter is placed is making the medication drip more to one side than the other. The medication drips in by gravity. So let your nurse know before it gets really painful, because the medication has to catch up with your pain.
Right.
And they'll reposition you to the side that is hurting more. And then within 10, 15 minutes, that pain should be gone. And then that's where you kind of start repositioning your patient and all of that. But worst case scenario, you should just feel that pinch, a little pressure, a little funny feeling in your back, maybe a zing down your leg. But those are the weirdest things you'll feel when you get an epidural. Worst case scenario, it will drop your blood pressure. We take your blood pressure every 2 minutes, and then every 5 minutes, and then every 15 minutes after you get an epidural. If you feel nauseous, dizzy, like you're going to pass out, we'll see those signs, but let your nurse know too, because then we can give you extra fluid and the anesthesiologist can give you medication to help your blood pressure stabilize. That's the biggest complication with an epidural is blood pressure issues, because that can affect you and the baby. So we keep a really close eye on that, to make sure that we stabilize that before going ahead and hooking it to the pump and infusing more of the epidural in you. So we watch you really closely for at least the first 30 minutes to an hour after you get an epidural to make sure like you and baby are okay and your body's reacting okay to it. Yeah.
So just to confirm what you were saying, when I had my second, the anesthesiologist, he was like amazing. He was so cool. We were just talking the whole time. And I asked him, is there, because for some reason, I don't know where I got this from, where like you think things and you're like, I don't know where I heard that, but I heard it somewhere.
You heard it somewhere.
I thought that, or heard it somewhere, that they don't like to give, or they won't give an epidural after 8 centimeters. And I don't know where I got that from. Anyways, I mentioned that to him, and he said, no, as long as you can sit still.
Yeah.
And he said, maybe someone said 8 because at 8 to 10, the pain's increased, and some women can't sit still. Maybe that was what was said. But he said, no, as long as you can sit still, you can have an epidural. Yeah. So yeah.
Well, another thing with that too, if you're if you're a second, third, fourth time mom, and you come in at 6 centimeters, 7, and your labor is going really fast, we need to know your platelets first. Some anesthesia providers it's very rare, give you an epidural without knowing your platelets, but they need to know your platelets first. So they got to send your lab work first. That's something actually.
So you have to wait for your lab work to.
So you have to wait for your lab work to come back, because if your platelets are too low, some providers will not do an epidural on you because it can cause a hematoma when they pull that catheter. That's super rare. That probably isn't going to happen to most of us unless you have preeclampsia or you're in HELLP syndrome. But that's something to be mindful of, that when you get to the hospital, you can say, I want my epidural now. But unless they have labs from like 1 or 2 days before that have your platelets, you might have to wait a little bit, maybe even up to an hour for those results to get back. And then they might be doing another epidural.
Right. Yes.
Or if it's night shift, the one anesthesia provider on the OB floor might be in a C-section. Right. That one mom I was mentioning who got to 9 centimeters, it was a nightmare night. And we had a scheduled C-section and then an emergency C-section. And then the anesthesiologist came out and did the person who was first in line's epidural. And then we had another emergency C-section. And there's only one anesthesia provider at night for OB. Now, like I said, in emergencies or certain circumstances, they can bring someone else over from the main side, which we had to do that night. But we also had someone who was a VBAC on the floor that night. And that anesthesia provider cannot be in the middle of anything. No other epidurals, nothing, just in case that VBAC mom has a complication. Which a VBAC is vaginal birth after cesarean, or you might hear TOLAC, trial of labor after cesarean. He could not do any of our epidurals. So this poor mom waited, and she was a first-time mom, 6 hours for her epidural. And like I said, she was screaming and cussing when I first got there. And I really had to teach her some mental, and emotional ways to calm down and control her pain. While she waited, I said, I'm so sorry. This is something that we really cannot control. Yeah. I'm so sorry. So keep that in mind. Yeah. You may want an epidural, but circumstances might make it to where you might have to wait a little bit. So I always tell moms, learn some natural coping techniques, or be open to taking IV medication, because that can help get you to your epidural. Or if you're second, third, fourth time mom, you might go too fast for an epidural. I had a mom I was sitting up for an epidural. It was taking a little long, and suddenly she goes, I need to push. I said, we're done. Laid her down, had a baby 10 minutes later. No way. So keep that in mind. Not to put fear in anyone's heart, but always have a backup plan. Always learn some natural coping techniques, or be open to IVP medication. Now, the IVP medication works great up until you're 8, 9 centimeters. After that, the pain is a little bit past the threshold of what any other IVP meds they can give you can do. But that is a really good, that's a really good tool that can get you to the point of, pass through and past transition a little bit, which is the hardest part on labor.
Yeah. That's good. All right. So, besides going over your due date, what are some common reasons that they induce labor?
Yes. So post dates is really important, because the longer, and I know there's a lot of talk in the birthing community about the necessity of certain C-sections. So I'll give my professional opinion. A post-date C-section, in my opinion, if you're over 41 weeks, is really necessary, because the longer you go, the less fluid your baby has, and the more your placenta deteriorates. So that's the number one reason why we do it. Sometimes your doctor may look at the size of your pelvis in relation to the size of your baby and say, hey, in my professional opinion, a C-section might be the safest way for this baby to come out. And they call it macrosomia. If you have gestational diabetes and your baby's measuring really large, or you have a history of a very large baby that caused the shoulder dystocia or a 4th degree tear, they might recommend scheduling a C-section, because, you know, we just don't want to run the risk again of your baby getting stuck during a vaginal delivery, and this next baby is looking very big as well. We want to like kind of bypass that emergency situation or trauma, which, you know, some moms will go for that. Other moms will try again and have a wonderful delivery. But if that's happened to you and it was a really traumatic experience, maybe a C-section is the best option for you. Sometimes you might be too sick. So if you have very severe preeclampsia, or you get something called choreo, where you get an infection in your uterus, or you have, you know, some kind of condition like a heart or any kind of other chronic condition that you might not be able to tolerate labor, or your baby might not be able to, that is another indication for a C-section. The other two, obviously breech. Very little doctors, if any, practice vaginal breech nowadays, even in an emergency situation. So the best recommendation and the safest recommendation is a cesarean section. I know there's one actual doctor here in Sacramento who does do vaginal breech deliveries, and I've seen one or two myself. One was not planned. Well, both were not planned. One, it was too late, like baby was already coming out, and the other one, we had a hospitalist from the United Kingdom who had trained in vaginal breech deliveries, and they did it in the OR, with everything set up for an emergency C-section if needed. But he was able to help that mom do it. But usually, in my personal recommendation, I would recommend a C-section, just because there's some complications that can happen. I'm just trying to get shoulders and a head out that way, that, you know, just can result in a really traumatic birth or a very bad vaginal tear.
Right.
Now, if you're in labor and you've been in labor and you are not dilating, they've tried everything. We've tried position changes. We've tried spinning babies, which some doctors and nurses might not do this. So this is another thing to advocate for yourself. They've tried Pitocin, they've tried breaking your water, and you're just not dilating. And it's been, I think there's guidelines, like protocols, like if you're a first-time mom, they will do everything they can to make sure that your first delivery is vaginal, or they should be.
Yeah.
Because once you have one C-section, you know, you can try for a vaginal birth, but just your risk goes up. So they will try everything to get your first baby out vaginally. And then if your baby is just not descending, or you are not dilating, or your baby's head is not descending, it's been at the same station, which the station is your baby's head in reference to your pelvis, and coming through the birth canal, or you've been pushing, I think you can push for 3 hours with an epidural as a first-time mom, and 2 hours as a multi, so second, third, fourth, you know, it's your second baby and on. You can push for like an hour or 2 hours with an epidural, and your baby's not making any progress. That's an indicator that this baby might be too big, or there might be some kind of, maybe a cord around the neck, or your baby's shoulders are just too big, some kind of abnormality that's causing this baby to not come out.
Yeah.
And the longer we push, the more stress your baby's going to get. So a doctor might recommend a C-section in that instance. And then obviously any kind of infection, fetal heart rate abnormality, you're getting dips with each contraction in the baby's heart rate, or your baby's heart rate strip is turning from, kind of questionable to worse. they're going to recommend a C-section, because basically what that heart rate tells us is how oxygenated your baby is and how they're tolerating your labor. And if your baby's not tolerating your labor, we just want to we're not even close to pushing, we can see signs that this baby may not even tolerate pushing either.
Right.
So there's some emergency situations too, where if your water breaks and you have something called a cord prolapse, where your water breaks and your cord comes out and is out of your, vaginal opening. That's an emergency, because then your baby's head is compressing onto the cord.
Right.
And that can cause cessation of blood flow and no oxygen to your baby. We'll see an immediate dip in your baby's heart rate when that happens. And it's kind of funny. The nurse literally has to go in and hold the baby's head up with her fingers.
So
as you're rolled back to the OR, yes.
So the baby's not pushing
on. Yes.
No
way. As a nurse, you are holding this baby's head up on the bed. They drape over you, and you are there until they get the baby out via C-section.
No way. Wow.
Yeah. I never personally had to do one, but I was actually doing an epidural with another patient, and my patient next door had a cord prolapse. And my charge nurse, babe, just came in. Her arm was killing her after, because she was holding that. Yeah. So that's like an emergency situation. If you have a placental abruption, where basically your placenta is coming away from the uterine wall, and you or the baby can suffer great blood loss, that's an emergency C-section. If you have a uterine rupture, whether it's from just labor and you have a thinner uterine wall, or from Pitocin, or from if you've had a previous C-section and where that scar is, you rupture, that's an emergency C-section. Also these are all very rare circumstances. I've never seen a uterine rupture. I've never seen a full-blown uterine or placental abruption. These are all really rare, but in these cases, this is, what you can expect. That's an emergency C-section. There is no discussion. There is they are getting your verbal consent. So just know that it's not them taking over your birth experience. It's literally a life and death situation. Because I know, and understandably so, women are becoming more advocates for themselves. Women are becoming more questioning of certain interventions. And I think that's great. But 9 times out of 10, a C-section is suggested because it's in you and your baby's best interest.
Right.
And we get the baby out and they look just fine. But if we would have waited 1 or 2 hours, they might not have looked fine, So biggest causes for a C-section would be breech, failure to dilate, which I hate that word, failure. I would say just success, the labor's not progressing.
Right.
The baby's head or shoulders are too big and it's not coming down, or a more scary situation, the cords are on the neck. And in that case, it's good that we did a C-section, because you can kind of see signs and symptoms in the baby's heart rate that tells you, this might be a cord around the neck. And you suggest, hey, we might just need to do a C-section because your baby will not tolerate either pushing or any more pushing. So those are the biggest ones. And then obviously the more emergent situations are immediate, we're going back.
Emergency.
Or if you're too sick, like I said, if you have very uncontrolled blood pressure, and we cannot control it with medication, or we can barely control it with medication, and you get put on magnesium sulfate, which kind of stalls labor, and we try to induce you and it's just not happening, and you and your baby are getting sicker, or if you have an infection or some kind of condition, then that might be an indicator for a C-section too.
Well, that's all really good to know. So here's a fun one. I think we're on to the fun ones now.
I know, past all the technical.
Yeah. What is your favorite memory as an L&D nurse?
I looked at this question and I was going through my brain, because L&D is so fun, because you just get the craziest and the sweetest moments all in one.
Yeah.
So there's so many stories, but I'd have to say my 2 favorite is, one, there was this mom who was 40 years old, and she hadn't had a baby in 20 years. very sweet lady. She was in great shape, so she was doing just fine. And she was having a baby girl, and I got report on her, and then we always try to look at our prenatal records and like the history of your patient after you get report. And I saw that her son had died the year before, and oh gosh, it's gonna make me emotional. Her son had passed away, and her son was like 18 or 19 in like an accident. And so we get through her labor, we get through pushing, we have the baby, or she has the baby. And it's like this beautiful moment, beautiful baby girl. And, after all the craziness of that, we're doing the recovery, and she's like, my son died last year, right? And I was like, yeah, I saw that. I'm so sorry. She's like, I know. She's like, but this baby's brought like so much joy. And she did so amazing. Like when it's been 19 years since your last baby, it's like you're a new mom.
Oh yeah.
And she did so amazing pushing, and the birth was like so emotional. And she just looked at me and was like, this baby is going to bring so much joy when there's been so much grief and sadness. And I was like, that's so I know. And it was so emotional. It was just like one of the sweetest circumstances. Yeah. And then I've had a few instances with teenagers where, especially with COVID, like their mom couldn't be there because they chose to have the baby's father there. And you almost become like their mom. And you almost become like that person for them. And, I've had them like cry and, be like, thank you so much. Or just moments where a first time mom, like my favorite memories are first time moms who just, do so much work pushing. And then we finally have this baby, or they only push for 20 minutes. And I look at them and I'm like, you are amazing. Like, just that high of like, that this is like one of the most special moments in someone's life and you get to be a part of it. And I had a patient who I got her, it was her and her boyfriend. And you could tell she really wished her family was there. And I helped her get to 10 centimeters, but then I had to leave. And I made sure she had a really good nurse, and she was starting to push. And she looked at me with like tears in her eyes, like, you can't stay. And I was like, I would stay if I could, I promise, but I'm leaving you in really good hands. And I got to go the next night and see the baby and see that's her.
So sweet.
And I would have stayed if I wasn't back that night. I really would have, but I had to be back at work that night. So I had to go home and sleep. But it was so amazing because you just realize like how much of more than just the physical support, you provide so much emotional and mental support to these women. And I've just seen so many instances where it's just like, wow, like
that's awesome.
It's so fulfilling. Yeah. And then you get the crazy moms who
are screaming
who make it so fun, and they just come in and they just scream a baby out, and that's fun too. So yeah, there's very little instances where I'm like, birth is always fun to me.
Yeah. And I'm so thankful that you shared your knowledge, and you were also very transparent about everything that you went through and have gone through. And I know it's going to be a blessing to somebody.
Well, thank you for that opportunity.
Yes.
And thank you for what you're doing.